Welcome everybody to the sleep module. Tonight we're going to discuss normal physiology of sleep. We'll touch on the pathophysiology of sleep, just an overview. We'll look at some different airway considerations in the management of sleep, and if we have time, we'll discuss different treatment options that are available. We have future online courses coming. So as we do each of these presentations, they will be made available in a library of videos that will be available on the Continuing Education Alliance. And there'll be plenty more FACE courses coming. So FACE stands for Functional Airway and Craniofacial Education. One of the things that when I first got involved with this, my background is in nursing and in critical care. I spent many years in the emergency department. So looking at how the human body works is one thing. Trying to figure out why so many people are ill is a completely separate thing. And when I started learning about sleep, it was as if all of a sudden I had this awareness that we were not taking into consideration 1/3 of our patient's life. So every day, if during those 2/3 of their day, during their waking times, they're making their best attempt to be healthy, and then during the remaining 1/3 of their day, they're not sleeping well, their sleep is not efficient, they don't get enough, it's fragmented, whatever it is, we'll discuss all those things. That will hamper all of their best efforts. So I really started to focus on sleep and eventually came to the realization that sleep and effective sleep depends on our ability to breathe. So then we start thinking about the influences on our airway. So we're going to discuss all those things tonight, and hopefully by the end of this session you'll have a much better understanding of how all these pieces of the puzzle fit together. And we're going to get started with our presentation. Okay, so Sleep Physiology Module 1. Sleep is the golden chain that ties health and our bodies together. This was said by Thomas Dekker. So when we read that statement, that's something we very well could read today in an article or even in a course like this. We have discovered that sleep is what ties health together, mental health and physical health. But when did Thomas Dekker say this? He made this quote way back he lived from 1952 to 1950. He lived from 1572 to 1623. So all that time ago, he was already aware of the importance of sleep. So when we're talking about sleep, we have to ask ourselves, which is more important, the quality of our sleep or the quantity of our sleep? And by the end of this presentation, you shouldn't have to guess about the answer to this question. So let's take a look at the different stages of sleep, because sleep is not just something where we close our eyes and open our eyes. Sleep is a period of intense activity. So when we start from that period of deciding that we should probably go to bed and we start drifting into sleep, that is stage 1. So the NREM stands for non-REM sleep. Stage 1 is where we just start to wind down. Our body begins to relax. You might have some of those twitches. You're aware of what's happening around you, and you could be woken because you are aware, but you just really don't feel like responding. Non-REM sleep, or stage 2, is when a person starts to disengage from their environment. And this is where physiologically our activity starts to slow down. So our heart rate, our blood pressure, our breaths, our temperature. So all the autonomic functions start to wind down to get us prepared for deeper sleep. And it's at this point that it's not so easily to wake a person up. Non-REM stage 3, 4. There used to be a stage 3 and a stage 4, and now it's combined into stage 3, or they classify it as slow wave sleep. This is where the body does the majority of its repair work. This is where growth hormone is released, and it's the deepest, most restorative stage of sleep. You don't have fluttering eye movements or muscle activity. You are getting into that deep sleep, and it would be very difficult to wake somebody up. Even if there was noises in the background, people talking, things happening around them, it probably wouldn't wake a person up at this point. And REM sleep stands for rapid eye movement. That is a phase of sleep all on its own. And it's at this point that the body, which has been going into this relaxed state, now switches, and the body becomes paralyzed and the brain starts to become very active. Breathing might intensify and not be regular. The eye movements start jerking in different directions, and the brain is using a lot of energy during this time. It's thought that this is the stage of sleep that we dream in, and that the reason our muscles paralyze our body is so that we don't act out our dreams. This is also a time, though, where our heart, our cardiovascular system will respond, perhaps to our dreams or activity in our dreams, but our blood pressure rises. And it's during REM sleep, when everything else is paralyzed, that men would have an erection. And in the absence of these things is where we start to see disorders. So this is a hypnogram that gives you a visual of what we just discussed. If you notice with the light blue, we go from awake and gradually fall into the different stages of sleep. The dark blue is our period of REM. If you notice, we don't gradually fade into REM. REM has a switch in the brain that goes from on to off to on to off. It's not a gradual incline. Whereas the awake, 1, 2, 3, we will go in and out of as the night occurs. And in fact, we do need to lighten our sleep at certain times during the night to allow us to move our body, to roll over, so we're not in one position for the entire night. That optimizes circulation and keeps us healthy. But but if you notice, as the night continues, our period of REM gets longer. So it's about 90 minutes from the time we decide to go to sleep and close our eyes and fall asleep to when we get our first cycle of REM. And we'll talk a little bit more about REM as we continue. So what makes us fall asleep? Well, we have a circadian rhythm. Circadian rhythm controls everything. And as we notice here, that we have peaks and valleys to our energy throughout the day. And probably most people don't need to be told that. We know that there's a period after lunch where we might feel a little sluggish. And then as the evening approaches, we start to feel tired. We want to go to bed. Even children and teenagers who fight to go to sleep and want to stay up all night are not capable of it. We have to sleep. And so the rising and falling is a buildup of adenosine in our system, which creates that drive for sleep. So once we've slept and met that need, then we go back into a period of wakefulness. And the body is really efficient and has specific times for taking care of different biological functions. If we look at this human circadian biological clock, the slide here, we see that after we've had our dinner in the evening, our body starts to wind down. Around 9 o'clock in the evening, as the sun is setting and the light is starting to decrease, we start to get melatonin secretion. The melatonin is what helps us to have that nice deep sleep. Around 10:30 in the evening or 22:30, our bowel movements will be suppressed. Otherwise, we'll be up all night going to the bathroom. So in anticipation of allowing us to have a period of rest, our body starts to slow down all its functions. It's because nighttime should not be a time for dealing with those bodily functions. Nighttime is a time of rest and repair. So from midnight, the hours between midnight and 2 o'clock is where we have our deepest sleep. So basically, any hour that you get to go to sleep before midnight and up until 2 o'clock are going to be very powerful hours of sleep, very important time of sleeping. Our body will be at its lowest temperature at 4:30 in the morning, and then we start to have hormones released, and our body starts to get prepped for awake time the next morning. So if you notice even that melatonin secretion will stop around 7:30. So melatonin plays a very important role in sleep, and it's produced by the pineal gland, and many people take it over the counter. Um, Long-term use of it is not recommended, but if you're looking to heal your sleep or get you back on a cycle, it can be used for that on a temporary basis, and it's not recommended to be giving it to children. It is a hormone. The other thing, if you notice, is that the highest testosterone secretion is in the morning as well, and when we wake up, we're likely to have a bowel movement because our bowels turn back on in the morning after they've been suppressed through the evening. So hopefully this gives you a better idea of how efficient our body is. And these are cycles that as much as we try to extend our day and get more hours in our day, it's at the loss of the body being of the body's repair system. Even other organs have timelines for repair. So basically learning to work in harmony with your circadian rhythm, learning to respect the timelines and our internal clock helps us to optimize health. Now we talked about that slow wave sleep, that stage 3, 4 that are combined. It's in this slow wave sleep time period that we get memory consolidation. So you'll find that people who have trouble with their sleep will start to have issues with word finding. They'll start to have some memory issues. When you start to feel that happening, we need to examine what does the sleep look like and are they getting enough of that slow wave deep sleep. So let's look at the hypnogram again. We've talked about the quality of sleep. We need to get all those stages, but let's now look at the quantity. What about those folks who say they're fine if they get 4 hours of sleep or 6 hours of sleep a night? If we look at this hypnogram, what we see is that they are going to be missing out on the majority of their slow wave sleep and their REM sleep, which is going to be very detrimental to their brain health. So if we were to ask you again, which is better, quantity or quality? I think it's pretty clear that we need both. We need to make sure that ourselves, and I talk about ourselves first because if we don't heal our own sleep, we'll be in no position to be caring for anyone else, but for our patients as well. If they're not getting all stages of sleep, they will start to get disease process, and if they don't get enough hours of sleep, they will miss out on the majority of their reparative sleep. Bottom line is, you will never have a successful program without addressing sleep. It doesn't matter what practice you are. You have to look at the sleep of your patients. So let's talk a little bit about what goes wrong when sleep is not efficient. Most of the time when patients come to you with an issue, all you're seeing is the tip of the iceberg. When someone comes to you with dental caries, for example, caries is directly related to an airway issue. A patient with cracked teeth, ground teeth, worn teeth, you might be seeing a patient to do dental work, but the, the mechanism that is causing that need is huge. There's so much more to consider than just looking at the teeth. What is the health condition that is leading this patient to have this disease process in their mouth? It's visible for everyone to see if we're looking for the appropriate signs. So we have to keep in mind that there are over 100 different sleep disorders. I have a list of them here. Snoring is by far number one, right? Snoring, upper airway resistance, obstructive sleep apnea, central sleep, insomnia. The majority of people complain about insomnia. Restless legs, all of these things. There's so many things to consider when it comes to sleep. In America, 95% of Americans complain about having insomnia at some point during their lives. In India, there has been no study done, no broad study done to see what these numbers would be. It would be a challenging undertaking given the population of India. However, it's estimated that about 30% would have insomnia. I think that might be low, but I don't know. I'm just saying those are what the numbers are. And insomnia can come in many different forms. Insomnia can be either the not having the opportunity to sleep or sleeping and then waking up frequently. So you go to bed, you finally get to bed, and you cannot get into those stage 1, 2, 3. You can't fall asleep. Or let's say you go to bed and you do fall asleep, but you wake up at 3 o'clock in the morning and you cannot fall back to sleep. It can be short term because of something on your mind, or it could be a chronic situation. But if you look at this slide here, we see the overlap between obstructive sleep apnea and insomnia. Why is there such a huge overlap? We will talk about the different mechanisms for insomnia, and you'll get a clear picture of why this is. But for the meantime, the majority of our participants here are in the dental field, and what they tend to be concerned about is obstructive sleep apnea, because that's something that you can impact. When we look at obstructive sleep apnea, there was a recent study done that showed the cost to society is close to $150 billion in the United States. So not only is there a financial cost because we're looking at workplace accidents and tragedies that occur there, car accidents, lost productivity, people calling in sick for work or not being able to complete their assignments, the disease process, the health implication, the cost, the rising cost of healthcare, all of these things are a huge cost on the system. Think about the human cost, though, of what it does for families and how it impacts the family unit. So what is sleep apnea? There's two kinds of sleep apnea. There's obstructive sleep apnea, which is where the airway collapses. Then there's central sleep apnea, where the brain forgets to tell the body to breathe. The brain and the diaphragm are not communicating with each other. In normal breathing, we should breathe through our nose. We should breathe through our nose, our sinuses goes down our throat, and there should be no snoring. But when we have a blocked airway or obstructed airway, the tongue falls back. So we see the epiglottis, the tongue, everything is relaxed, the muscles and the back of the throat are relaxed. That's as the air goes through, it's going to create noise. There's going to be the tongue flutter. That's where we're going to get snoring. So unfortunately, it is such a common condition that people think it's normal. But as healthcare providers, we can't fall into that trap of thinking that just because it's common, that it's normal. We have to help our patients to see that it's not normal. So the cycle of sleep apnea is one that begins at sleep onset. As we fall asleep, we get decreased muscle tone, the tongue falls back, and the airflow is decreased. Our carotid bodies sense the change in the oxygen and carbon dioxide levels and tell the brain to increase the effort. So you'll see that there'll be increased movement of the diaphragm, the abdomen, but there's no air getting through until finally the person gasps or snorts and clears the airway and has relief from that obstruction, and they go back to sleep, and the same thing happens again and again. And the patient themselves is likely completely unaware of this. And that's the irony, that a number of the people that we speak to have no idea that they have this. But the bed partner usually does, the family usually does, and sometimes there are cultural things that people don't see that snoring is an issue, even though they're suffering the consequences of it. They might have diabetes, they might have high blood pressure. They're not necessarily making that connection that what's happening during their sleep is what's leading to their poor health. It's up to us to teach them that. Our patients may not come to us and say, I think I have sleep apnea. They might come to us and say, I wake up in the morning with a really dry throat or sore throat, or I have this dull aching headache every morning, or I'm worried about my memory. I seem to be forgetting things or having trouble finding the words for things or names. In children, we might see attention deficits. We see it in adults too, though, believe it or not. More and more adults are being labeled as ADHD or having trouble controlling their thoughts. They might become depressed and moody or anxious. They might complain about being tired all the time. One thing that people think is a normal part of aging is nocturia. They think getting up to go pee through the night is just an irritation and a normal part of aging. But it is not normal. It is a sign that the heart is not functioning well, that it's being stressed because of the apneic events that the person is experiencing all night. We talked about the release of testosterone in the morning, and that impotence is a sign that the patient is not getting the cycles of sleep that they need. They're not getting the testosterone that they need. And impotence is something that needs to be spoken of, and we need to make our patients feel comfortable to speak about it. We need to ask them about it because testosterone has an effect on so many other functions, including our muscle, our endothelial tissue, our heart. It is an important hormone, the same way estrogen is an important hormone for women. We have to talk about it more. A patient might complain of insomnia, and I showed you before the overlap with obstructive sleep apnea. They might actually have obstructive sleep apnea. And how could that be? Well, if we think about the fact that the person, when they go to sleep at night, is not breathing, and the brain, when it's supposed to be repairing our body and taking care of us and fixing whatever is broken to get us ready for the next day, if it can't do what it's designed to do and instead spends the entire night trying to keep us alive by activating our sympathetic system, then we are not going to be able to sleep at night, because as nighttime approaches, it our brain will become anxious. It will try to keep us awake rather than let us get back into a state where we might not be able to breathe. The diseases associated with OSA are huge. So let's just we'll talk about a few. So hypertension. High blood pressure is another one of those things that people just think is normal. It is not normal to have high blood pressure. That is a sign that our tissues, our vessels, are becoming inflexible. Why do they become inflexible? Well, one of the things that we'll talk about is mouth breathing, and the difference between mouth breathing and nasal breathing, and the fact that breathing through our nose in a calm, controlled manner helps to release the nitric oxide from our sinuses into our body and helps our tissues to relax. Excuse me. But if we're not getting oxygen through the night, if we're hypoxic, if our heart has to work overtime, pumping, and our lungs are pumping, and our diaphragm is pushing, and our whole body is working hard just to get us to breathe, we will have a sympathetic response, and that will increase our blood pressure. It will also increase our heart rate. And for some patients, when you look at their sleep studies, it looks as though they've been running up and down the stairs all night. It leads to a twitchy heart, and these patients end up with atrial fibrillation. The damage that's done to the heart and the pacemaker of the heart ends up causing bradycardias, and they have to get a pacemaker put in. The metabolic stress on our bodies from having to go through this night after night contributes to diabetes. The shifting of the heart with the intrathoracic pressure every time we have an apneic event leads to congestive heart failure or right-sided heart failure. We wake up exhausted. We did not get efficient sleep. Our brain needs energy. It drives us to want to have high calorie, high fat foods in order to get the energy it needs to go through the day. And not only that, but the leptin and the ghrelin, which control our hunger and our satiety, become reversed. So we never feel satisfied. We are always hungry. And what are we hungry for? The high calorie, high fat foods. You take this combination of symptoms, and a person goes to the doctor. We're going to give them the blood pressure medications. The blood pressure will never become resolved. It will never decrease if we are not managing the sleep. So patients tend to end up on one medication, two medications, three medications, or more to manage their blood pressure because we're not looking at what the underlying issue is. And the number one, the most deadly pathophysiology associated with obstructive sleep apnea is a heart attack in your sleep. 91% of them had sleep apnea, which is why they died in their sleep. And the difference between having a heart attack during the daytime versus a heart attack in your sleep is that a heart attack during the daytime where you suddenly fall tends to be an electrical event, or you might have a clot. But during the nighttime, in addition to having those issues, you've had periods without oxygen, you have no reserves, you're acidotic already because you have not been breathing appropriately. So the chance of reviving somebody or saving somebody from that type of a scenario is very, very low. So when we're talking about obstructive sleep apnea, it is a very serious disease, and even though it just seems to have recently really gotten a lot of attention, it's because the science is finally catching up with us so that now we have more than enough proof that we need to start addressing this with our clients, to push through whatever uncomfortable feelings we might have, to start talking to our patients about their sleep. And if you're a dental provider, I will show you the signs that you can see in their mouth to start the conversation with them. Excuse me. So, increased prevalence of medical disorders in those with insomnia. If we look at this graph, we see that these conditions, when they had no insomnia versus having insomnia, it's very clear to see that not sleeping. So before we were talking about with obstructive sleep apnea, the quality of the sleep, we talked about the overlap between obstructive sleep apnea and insomnia. And now we're looking at this chart that shows us that insomnia has a huge effect on heart disease, cancer, high blood pressure, everything we just spoke about in the last slide. So whether somebody is showing you data on a sleep apnea, a sleep disorder of any kind, restless legs, parasomnia, insomnia, the fact is if the sleep is broken, our patient will be broken too. It's just impossible to have a healthy patient that does not have healthy sleep. What about secondhand sleep disorder? So perhaps it's not your client that technically has a sleep disorder, but they're complaining about their bed partner that snores all night and they can't get any sleep. And I purposefully used this slide here and showed a woman snoring and the man not being able to sleep because we frequently stereotype and say that it's the man that has a snoring issue or the sleep apnea and the poor woman is suffering. But I've heard from many men who say, how do I tell my wife that she snores? Or they say, I would never dream to tell my wife that she snores. So that means then there are a number of women out there that have sleep issues that need to be resolved. We're afraid to approach them about it because we don't want to hurt their feelings. And it's because of the stigma that society has put on snoring and sleep apnea. It's what's seen on TV and in the movies, and people make fun of folks that wear a CPAP machine, for example, that they look like Darth Vader, or there's a connotation that comes with it. And for women in particular, when the stereotype is always a picture of a middle-aged man, maybe overweight, and then we try to tell a woman that you have this disorder, and in her mind she's picturing this overweight gentleman, there's a disconnect. And so what the studies are showing us now is that it is not just middle-aged men, it's not just obese people, that there are many people that are very thin that have obstructive sleep apnea because they have anatomically narrow airways. Or we have bodybuilders, athletes, very fit people who are dying of sleep apnea because they don't realize that the muscle that they build on the outside is also narrowing their airway on the inside of their throat. So we have to change our perception of what sleep apnea looks like in order to help our patients to be able to accept that there are very many different phenotypes of sleep apnea. When we look at this again, what if you're the spouse of somebody who sleeps or snores and you have to keep waking up? Not that you have to, your brain is paying attention. While you're trying to sleep, it's paying attention to your spouse. And it is noticing if your spouse stops breathing. And because you care about that person, your brain wakes you up and makes you elbow your partner, makes you push them over onto their side. Our brains never sleep, so they're always aware of what's going on. So it's very difficult to be the bed partner of somebody who has a sleep disorder. Both of you, if one of you has a sleep disorder, you both have a sleep disorder if you're in the same room. And what are the effects of that? What I mentioned before, we have to think about the human cost of these sleep disorders. It's because when a person has this, and think about how you feel if you didn't have a good night's sleep. if maybe you went several nights without having good sleep, you would become irritable. And we all know that. We've experienced that, where we just feel like, I have to sleep. And you start snapping at people and you don't say the right thing and you know it as it's coming out of your mouth, but you just can't help yourself. There's a psychosocial effect from sleep deprivation. We talked about the physiological changes that take place, our reaction time. So think about people that are in those professions that need to be reactive, that need to be aware, that need to be fit for duty. We have our air traffic controllers, our pilots, police officers. I mean, people who have other people's lives in their hands. What about a doctor? Working. Sometimes we think in the medical profession we can work 12 hours, 24 hours, 48 hours, 36. So we're heroes because we can work so long with so little sleep. And we wear it like a badge of honor that we can get by on very little sleep. But the only person we're fooling is ourselves, because the studies show that after 16 hours, all of your reaction times, all of your reasoning abilities start to degrade very quickly, so that a person who's been up for 24 hours it has the same reaction time and ability as somebody who's intoxicated. But the thing is, just like the intoxicated person that thinks they're fine, thinks they're okay to drive, a person who has sleep deprivation does not feel or understand or know how much of a danger they are in that moment. And when somebody has had loss of oxygen to their brain, night after night after night, it does damage the brain tissue. So just like if you had somebody with a traumatic brain injury or a concussion, and you would expect that there would be deficits from that, this is something that is slow and over time, but it creates deficits. What about our children? Do you think that this would have an effect on our children and their ability to do well in school? If we think about the time, how much time our children sleep, do they get the 10, 11, 12 hours of sleep that they need? Are we keeping them up to do homework and they're getting 5, 6, 7 hours of sleep? A child needs way more sleep than an adult. And if our child is struggling at school, it has learning issues, we should be digging deeper to find out how well they're sleeping, because it's during sleep that their brain function is restored, that their memory and their consolidation of what they've learned and their abilities, all of that happens during sleep. And yet, we are, as a society, um, trading sleep in exchange for completing homework, projects, and assignments. So the effect that this has on our children, though, from not getting enough sleep is taking a huge toll. And if we look at what it's leading to in terms of behavioral issues, and we were to look at these children, I mean, we would think that they were out of control. But you and I know what it feels like when we don't have enough sleep. We've been socialized to behave a certain way as we get older. Children are not socialized from birth for that. So when they are tired, they act out. And when they're babies, we know, okay, this child needs to go to sleep. It's nap time. And we put them down for a nap. But as they get a little bit older, um, we're not so much about the naps. And our children's behavior from sheer exhaustion is leading them to be diagnosed with oppositional defiant disorder, uh, attention deficit disorder, attention deficit hyperactivity disorder. These so-called disorders are leading to this epidemic in America of children being placed on psychiatric medication from a very young age. And I'll tell you something that's happening here is that babies as young as 2 years old are being diagnosed as depressed or anxious or bipolar and being put on medications. And I think it's a sign as well that the parents are sleep deprived and don't know how to manage their children. And so everybody is becoming medicated. It's kind of gotten out of control. And the bigger issue is that these children who then get diagnosed with oppositional defiant disorder or whatever behavioral issue they get diagnosed with end up becoming the juvenile delinquents that are housed in our many, many juvenile detention center hall. It's a huge issue for our young people. So we need to take this bull by the horns and start looking at how to prevent it. And the first step, I would say, is to ask yourself, what challenges do you have in obtaining a good night's sleep? Do you think the quality of sleep that you have right now is going to help you to have resiliency long term, to be able to live your life to the fullest? We all want to live as long as possible, but living as long as possible with a quality of life um, that is suffering because of the consequences of poor sleep or from a sleep disorder like obstructive sleep apnea and having high blood pressure, having diabetes, and those types of things, is it worth it? Or is it a better choice to start looking at our sleep, taking care of our sleep the same way we take care of our diet, nutrition, exercise, and our mind? So we're going to talk a little bit about testing. How do we know? Because sleep disorders, we talked about how there's over 100 sleep disorders. It's not something you can look at somebody and tell. And that's the number one mistake doctors make when they get involved in sleep medicine, is thinking that they can spot it. And when we talked about stereotyping, what we think sleep apnea looks like in our patients, this is what I'm talking about. We're not guessing. We're scientists. We're in the healthcare field. When we have a patient come in, we don't guess what their blood pressure will be. We actually take their blood pressure and we trend it over time to see if our patient has an issue. So we don't guess about where the where the cavity is. We're going to take an x-ray. We're going to use the technology that's available to us to make sure we offer our patient the best support we can. So one of the tools that we use is called the Epworth Sleepiness Scale, and it gives an indication of how tired our patient is during the day. So on a scale of 0 to 3, we ask them, how likely are you to fall asleep while sitting and reading? How likely are you to fall asleep while watching TV? While sitting inactive in a public place? How likely are you to fall asleep as a passenger in a car for an hour without a break? Or if you were able to lie down to rest in the afternoon, if you're sitting and talking to somebody, would you be likely to drift off and fall asleep? What about after lunch? You've had a great big meal and no alcohol, but would you feel inclined to sleep? And if you're in a car, but you're stopped for a light or traffic, do you feel yourself nodding off? So each of these questions is scored on a 0 to 3, and then anything over 16 would be considered high and worth pursuing. Another questionnaire that I like this one because it has some more objective data on it rather than just asking. One of the things I find with the Epworth is some people will not answer it as accurately if they're worried that you're going to judge them. That, for example, if you say, some people don't want to admit that they fall asleep when they watch TV. So they won't answer it correctly because they think that it means you're going to put a meaning to it, that they're lazy or not motivated. So I like this one here, the stop bang, a little bit better because it has objective data. So we're going to ask them, do you snore loudly? Do you feel tired? Has anyone ever told you that you stop breathing or that you gasp during your sleep? Do you have high blood pressure? What is the body mass index? If we can look to see, is it over 35? Is the person over 50? Is your neck circumference greater than 17 or 16 for females? So if they know what their shirt size is, that usually helps. Is your gender male? So here's a perfect example of where we tend to think that over 50 and male has a higher risk factor. So over 50, obese, thick neck, and male is one of the highest proportions that we're going to see. But a woman who has gone through menopause is at the same rate. Because when the hormones change, the muscles relax, and she becomes at the same rate. Her risk increases. So many people know about sleep testing, and the polysomnogram test is one of the most accurate because it tests everything. It has electrodes to read your brain waves. It has electrodes over your eyes to check for rapid eye movement. It has EMG on your masseters to check for brexing and clenching. It has a belt for respiratory effort. It has electrodes to check for periodic limb movement disorder. So it's very comprehensive. I think in India, the sleep program was instituted in India in 1992, and it has made rapid strides. I still don't know that there's enough to manage the number that's there. That's one of the issues is the bottlenecking of patients and not enough lab facilities. So what in America, what they use is portable sleep testing, and I know that there are some in India as well. What portable sleep testing allows you to do is to have the patient be in their own home. It decreases costs, but it doesn't give you as much information, but it gives you information to let you know if this person has a glaring obstructive sleep apnea issue. Because the number one thing we're looking for is the patient breathing? Airway, breathing, circulation. We know airway always comes first. So if we could rule out the majority of sleep disorders, which is obstructive sleep apnea, if we could rule at least that out and start addressing that number and get people breathing again, we would be able to have a huge impact on the healthcare system. So these portable sleep testing units are good for that, but they're not good for ruling out, if that makes sense. They rule in. So if it says, yes, we see this oxygen decrease and we see he stops breathing this many times, excellent. But if it comes back and it doesn't show us that and the patient's signs and what they're complaining about indicate there's a problem, we cannot rely on that portable sleep testing to diagnose that patient. They need to go for further testing. But in terms of screening this population and trying to help as many as we can, it is effective. So what are we looking for? We're looking for the apnea-hypopnea index. So let's talk about what that means. So an apneic event or an apnea is when you stop breathing for a period of 10 seconds or more. And a hypopnea is when the oxygen level begins to drop. And we're looking for how many times did the person stop breathing and have a drop in oxygen per hour. So Dr. Christian Guilleminault, who has been a huge researcher in sleep, was asked at one point to give a range of what we could look for in terms of what do we treat, what don't we treat. He came up with this scale, and he always regretted it because he said, he was trying to provide a guideline, but let's think for one moment about the less than 5 per hour. So if we were to look and say, okay, this person has none or minimal sleep apnea, he has less than 5 an hour, I would ask you how you would feel if somebody woke you up 5 times an hour. At the beginning of this presentation, we talked about that hypnogram and the stages of sleep and being awakened during those stages of sleep and interrupting sleep and creating that fragmented sleep. If somebody woke me up 5 times an hour, that would cause fragmented sleep. It would cause a rise in my sympathetic nervous system, and it would create all the types of disabilities that we discussed. So saying that somebody has mild or a little bit of sleep apnea is really, it has the potential to damage our patients because we're not impressing upon them the severity. So not only are we being woken 5 times an hour, but an apneic event is counted if it's over 10 seconds. How long does that apneic event go? I have seen where patients stop breathing and they don't breathe for almost 2 minutes, and their oxygen drops right down from 100 into the 70s. So that is an intense apneic event, but it would still only be counted as one. So that's where I'll have more courses coming, but one of them is just looking at the sleep testing and what does the report tell us? I don't want to just come and look at this report and say, okay, this person had 4 events an hour, but not discuss the fact that those 4 events an hour lasted 2 minutes long and the patient became severely hypoxic with an O2 sat in the 70s. That caused brain damage. Any saturation that goes below 90 is going to cause a death of tissue in the body. So that person is going to be highly susceptible to cancer, to inflammatory process, autoimmune process. Like it has a huge effect. So we'll discuss that more at another time, but I just want to give you a sense of some of these numbers you're looking at. So mild would be 5 to 15 apneic events an hour. Moderate is 16 to 30, and severe is over 30. I would say the majority of people, by the time they show up in your office or they're willing to come forward and complain about this intense level of fatigue that they have, the majority of them are in the moderate range already. And that's significant because sleep disordered breathing is on a continuum. So if you're just a snorer right now, but the sleep test says you're less than 5, so they're going to say we don't need to worry about it. But years go by. I've had people say to me, oh, I had one of those tests done. It said I was mild. And I ask them, how long ago did you have that test? And they will say, oh, it was probably about 7 years ago. Well, do you think that in 7 years the disease progressed? Absolutely, it progressed. And so as a healthcare provider, if we see our patients, they address an issue, and it comes back mild, maybe the patient doesn't want to do anything about it, are we scheduling them for follow-up with the understanding that left untreated, this disease will progress? It rarely goes the other way. I just want to say something here too. So there's a patient that had sleep apnea, was on a CPAP, lost 100 pounds, stopped wearing the CPAP. This happens time and again when patients wear the CPAP and all of a sudden the brain starts getting the support that it needs. It gets the oxygen it needs during the night, starts doing the job that it was supposed to do, starts repairing the body. Patient's not so tired, so they're not looking for high calorie, high fat foods. They lose weight. When they lose weight, they convince themselves that they no longer need the CPAP machine. But what they don't realize is that all of those years that they went with the untreated sleep apnea did have an effect on their heart. And this one patient I know, he went off of the CPAP and was very proud of himself, very happy about that, only to later on be admitted to the hospital for cardiac failure, because the muscle of his heart had gotten so enlarged from all the work it had to do when he wasn't breathing for all those years. And so now not only is he back on CPAP, but now he has an implanted defibrillator. So it's not just snoring, and I think you get that by now. We already talked about the different types of sleep disorders, so I won't go into that very much more except to point out restless leg syndrome and REM sleep behavior disorder. So if you recall when we talked about REM and that the muscles in the body is relaxed to the point where it's paralyzed so we don't act out our dreams. There are people who during that time period are not paralyzed. And in fact, their legs kick and flutter and they move about. And in this time, we tend to see more bruxing of their teeth. And so there's a neurologist, Dr. Gomanak, who says that this is vitamin D3 mediated. The vitamin D3 is actually a hormone that acts on the part of the brain that provides you with REM and paralyzes you in REM. And if your vitamin D3 level is low, you will have these types of disorders. And it might seem strange in a country like India for people to have low vitamin D levels because you have such beautiful sunshine all year long. But the fact of the matter is, if people work indoors and don't have exposure to the sun, if people's skin is darker, it makes it more difficult for the sun to penetrate the skin to form the vitamin D in through the fats in our skin. And so what we see is this huge epidemic of vitamin D3 deficiency. So managing those levels in our patients and finding out what they are is going to be huge because those for dental providers will be your clenchers and your grinders. They'll be the people who have headaches all the time. Um, and it affects periodontitis. Uh, it affects calcium buildup. We'll do another course just on vitamin D3 to share all of that with you and how it impacts what you're doing. Let's talk about children for a minute. So with adults, we think snoring is huge, okay? Snoring is going to be a big factor, but we're not necessarily going to see that in children. They might. I have seen and I have heard children snoring, and let's put it this way, snoring is never normal. It's never okay. It's like a built-in alarm system to tell you there is a huge problem here. Air is not getting through. If somebody during the daytime all of a sudden started snoring, was laying there snoring, I know in the emergency department, we would be looking to intubate the person. If they're snoring, the air's not getting in, their oxygen's dropping, we would intubate. A child will be the one that's spinning around, moving around a lot, waking up screaming, having nightmares, sweats. They wake up and they're wet and sweaty. They tend to wake up frequently. These are the ones who are driving you crazy because they just seem to never want to sleep. And then the other part of it is that they'll have night terrors. So they'll have night terrors because their sympathetic system gives them that little shot of adrenaline when they're not getting enough breath, and they'll wake up. The other thing is bedwetting is huge. If you have a child that's 4, 5, 6, 7, 8, and they're still wetting the bed, you need to be checking their sleep and their airway. I wanted to point out about if you take your CPR class and you remember when we're doing the pediatric life-saving, you take their head, you tilt it back to that sniffing position. Think about the children when they're sleeping that have their heads cocked right back. They are opening up their airway by doing that. So that's when we talk about unusual sleeping position. It's them wrenching their head back, or you see them on their in a kneeling position, almost with their bum up in the air. That forward position is helping to keep the tongue forward. So, one of the things when we talk about problems with sleep is we can really get ourselves into a tizzy. We could be convincing ourselves that we're not going to be able to sleep. We could be afraid to go to sleep because now somebody's told us that we're not breathing during our sleep. And this anxiety just further exacerbates the problem. So helping our patients to calmly accept and recognize and know that we're going to support them through this is really important. However, a lot of times our patients come to us and say they are tired, they're exhausted, they're dragging, and we think that they have a psychological problem, that maybe they're depressed. I see that here a lot of times when people say they're tired, first thing that's offered to them is an antidepressant. But you cannot talk somebody out of a physiological problem. If their airway is obstructed and if they're not getting enough sleep, all the counseling in the world is not going to help them. We have to address the underlying issue. And that's the same for children as it is for adults. Okay, so treatment referral options. What are you going to do with these folks? CPAP, we know CPAP is frequently used. There's positional therapy. So we want to encourage our patients to sleep on their side. That's going to be huge. How you do it is up to you. There's so many different devices over here, and I don't know what positional therapy. I've seen a couple at some of the sleep conferences I've been to in India. This is one of my favorites, though. This is such a comfy. It's called COPAP pillow. Oral appliances, that's what you're going to do. So in medicine, when a patient comes in and they're not breathing, we do a jaw thrust maneuver. We push the mandible forward to get the tongue out of the way. That is what dentists are doing when they make a mandibular advancement appliance, oral appliance, whatever you call it. It's the device that is used to bring that jaw forward and get the tongue out of the way. Some people offer surgeries. So surgery removes some of the tissue to open the airway. Now, theoretically, it sounds like a good idea, but when you have obstructive sleep apnea, there's 4 possible points of obstruction from behind the nose and behind the throat. So removing this one point might have a temporary effect, but it may not be the full effect for you. And what we see is scarring and sometimes stricture occurring, and people have to have it redone after a couple years and find that it doesn't really give a permanent solution like they thought it would. Myofunctional therapy. So what's interesting is as we go on this journey together, more and more what we see is that these breathing issues, the sleeping issues, are related to our ability to breathe. And the thing that impedes our ability to breathe is the tongue falling back or sitting low. And as long as that tongue is falling back and sitting low, our maxilla will not develop properly. We will not be breathing through our nose properly, and we will be set on a path that as we grow and mature will for sure lead us to have sleep apnea. So starting young with children, teaching them to close their lips while they're eating their food, breathe through their nose, can go a long way in preventing issues. But when the issues are already there, myofunctional therapy is like a physio for the tongue and mouth area to strengthen that tongue and put it where it needs to be and keep it out of the way. So we're starting to see a lot more of this being implemented into dental practices. So thank you all for joining me tonight. I did want to let you know that we will be in India. We are coming March 27th to the 29th. That is going to be the Indo-Russian Congress. It's with ICMO, the International College of Craniomandibular Orthopedics. I think I've met many of you at the last one, which was so much fun to meet all of you. It was a fantastic event, and we're going to have an even better event this time. And Russia will be joining us, and there'll be doctors from the Philippines, a lot coming from North America. So we're looking forward to seeing all of you again. The course tonight is part of a program. If you're not already signed up as an airway advocate on the Foundation for Airway Health site. I would encourage you to do that. You go to www.airwayhealth.org, and under practitioner, you take the pledge, sign up as an airway advocate so patients can find you. The number one issue we have with all the education and outreach that we're doing is there just are not enough providers to care for these patients. So your services are desperately needed. Make yourself be seen by making sure you sign up on there. And then I will be offering courses similar to this. We go a little bit deeper each time. Tonight's course was very basic, a quick overview, but we will go into each of these topics more deeply so that you gain a confidence with it. And my biggest goal is to really connect medical and dental. It's a challenge everywhere we go. But really, medical has patients with so many problems that we can only get so far with, and we need the dental community to take it the rest of the way. Because a lot of what is the patient's issue is craniofacial. It's airway, it's their teeth, it's the crowding, it's the inability to breathe through their nose because their palate is too high, it's vaulted, and all of these things that dental really going into this next decade, I believe will take over in terms of having the dramatic effect on healthcare. I'm also affiliated with the Indian Society for Sleep Research, and they have courses and events every year. So if you want to attend those, just reach out to me and I'll let you know when those are coming up. But otherwise, thank you all so much for joining us tonight, and we'll see you next time. Thanks.